Did you know your heart beats approximately 100,000 times per day, pumping about 2,000 gallons of blood? It's a marvel of natural engineering, tirelessly working to keep us alive. But sometimes even this organ fails, and when it does, science steps in, pushing boundaries we never imagined. Just in 2022, David Bennett became the first person to receive a genetically modified pig heart transplant. Yet as even technology advances, a sobering reality persists. Heart disease mortality continues to rise. It remains the leading cause of death, globally responsible for an estimated 941,000 deaths in the United States in 2022 alone. By 2050, we're staring down the barrel of a projected 90% increase in cardiovascular disease prevalence globally. This isn't just about numbers. It's about people, families, and immense challenges. And as we advance our ability to treat heart disease, especially with cutting-edge procedures like transplantation, we confront profound ethical questions. Questions about fairness, access, and the very definition of life and what we're willing to do to save it. Heart disease isn't just a medical issue. It's a major public health crisis with significant economic and social impact. It places a considerable burden on healthcare systems and affects families deeply, particularly low-income families who may face significant financial strain from long-term treatments. Heart failure, a prevalent form of heart disease affecting over 6.7 million people in the United States, is notably the leading cause of hospitalization for older adults. This number is projected to climb to 8.5 million by 2030. Understanding the heart, its vulnerabilities, and its implications of disease is critical. From prevention through lifestyle choices to the most advanced surgical options, the journey through heart health and disease forces us to confront limitations, both biological and societal. Our ability to save lives has advanced dramatically, but the resources, particularly organ donors, are finite. This scarcity compels us to consider difficult ethical dilemmas. Who receives the life-saving transplant when there aren't enough organs for everyone who needs one? What principles should guide such life and death decisions? To understand the challenge, we must first understand the heart itself. It's a complex muscular organ located in the middle mediastinum of the thoracic cavity, the chest cavity, typically oriented with its apex pointed anteriorly. About the size of a closed fist, it weighs between 7 and 15 ounces. The heart wall has 3 layers: the outer epicardium for protection, the muscular myocardium responsible for pumping, and the inner endocardium lining chambers and valves. Structurally, the human heart, has 4 chambers: 2 upper atria that receive blood and 2 lower ventricles that pump it out. This design efficiently separates oxygenated and deoxygenated blood. Deoxygenated blood from the body enters the right atrium, moves to the right ventricle, and is pumped to the lungs via the pulmonary artery. Oxygenated blood returns from the lungs to the left atrium, flows into the left ventricle, and is pumped to the rest of the body through the aorta. This blood flow is precisely controlled by 4 critical valves: the tricuspid, pulmonary, mitral, and aortic valves, which ensure blood moves in only one direction, preventing backflow. The rhythmic contractions of the heart are orchestrated by an intricate electrical conduction system initiated by the sinoatrial, or SA node, in the right atrium, which acts as the heart's natural pacemaker. This impulse spreads through the atria and then via the AV node and the His-Purkinje network into the ventricles. This coordinated process makes up the cardiac cycle, involving the filling and the pumping, filling diastole, the pumping systole, phases, occurring roughly every 0.8 seconds in a healthy heart. The heart's rate and rhythm can be adjusted by the nervous system to meet the body's changing needs, like increased demand during exercise when the heart rate increases, or slowing the heart rate down when you're sleeping. However, various conditions can compromise this vital organ. Heart disease encompasses conditions like coronary artery disease, heart failure, arrhythmias, cardiomyopathy, and congenital heart disease. Coronary artery disease, the most prevalent form, involves plaque buildup, atherosclerosis, in the coronary arteries, reducing blood flow to the heart muscles. This can lead to angina or a heart attack. Heart failure occurs when the heart cannot pump effectively, while arrhythmias are irregular heartbeats. The causes are varied, including risk factors like high blood pressure, high cholesterol, diabetes, obesity, smoking, and a sedentary lifestyle. Genetics also may play a role. Thankfully, the treatment landscape has evolved significantly. Initial management often involves lifestyle modifications such as heart-healthy diet and regular exercise alongside medications like ACE inhibitors for high blood pressure, blood thinners, and cholesterol-lowering drugs to manage symptoms and other risk factors. For more severe issues, interventional procedures like angioplasty and stenting can open blocked arteries. Surgical treatments like coronary artery bypass grafting or heart valve surgery address blockages or damaged valves. In advanced cases, mechanical support devices like a ventricular assist device or even total artificial hearts can bridge patients to transplant or serve as a destination therapy. This brings us to the frontier, heart transplantation, a crucial procedure for patients with end-stage heart disease, particularly cardiomyopathy in adults and congenital heart disease in children. Since the first human heart transplant by Christian Bernard in December 1967, which sadly saw the recipient live only 18 days, advancements in surgical techniques and immunosuppression have led to significant improvements. For pediatric treatments in 2022, the 1-year survival rate was 91.7%, 5-year survival rate was 84.4% for transplants performed between 2016 and 2018. Adult post-transplant mortality rates at various intervals have also seen favorable declines since 2012. The process has become more efficient, with an increasing rate of listed patients receiving transplants within 3 months. However, despite these medical triumphs, a fundamental challenge remains: the scarcity of human donor organs. The growing demand for hearts far outstrips the supply of compatible donor organs. This scarcity creates a stark ethical dilemma. Who gets the heart? How do we decide who receives a potentially life-saving transplant when not everyone on the waiting list can? This is where ethical frameworks become essential tools, even as they sometimes conflict. One framework is utility, which suggests maximizing the overall benefit, perhaps prioritizing patients with the highest probability of survival and the best quality of life post-transplant. Another factor is justice, focusing on ensuring equitable access and fair distribution, avoiding discrimination based on wealth, social status, or other non-medical factors. Medical urgency is a key consideration. Is a patient on the brink of death prioritized over someone who could potentially wait longer, even if the latter has a better long-term prognosis? Age also factors in. Some frameworks, considering prioritizing those who have lived fewer life cycles. The challenge isn't just about human donors. The recent xenotransplantation case, where David Bennett received a genetically modified pig heart in 2022, introduces a new layer of ethical complexity. While offering a potential solution to the donor shortage, it raises serious questions about patient safety in experimental procedures and the necessity of truly informed consent. It also forces us to confront ethical considerations regarding animal rights, using animals as a source of organs. Furthermore, some individuals may have religious or cultural objections to receiving organs from animals. Beyond the allocation committee room, socioeconomic factors significantly influence access to care and health outcomes. Studies show a significantly higher risk of mortality for individuals from low and middle socioeconomic levels compared to high socioeconomic levels. Residing in poverty-stricken or rural areas are also identified as critical risk factors. This highlights how Societal inequities compound the medical challenges and the ethical dilemmas in heart health and transplantation. Imagine you are part of a hospital transplant committee faced with a difficult decision. A single compatible donor heart becomes available, but two patients desperately need it. The first patient, patient A, is a 16-year-old with congenital heart disease. They have an excellent chance of surviving for decades with a transplant. They are currently stable enough to wait longer, but their health is declining. In comparison, the second patient, patient B, is a 55-year-old single parent of 3 young children with acute heart failure. Their overall life expectancy post-transplant might be shorter than patient A's, but they will die within days without immediate transplant. How would you decide? What ethical principles should guide your decision? There isn't one single right answer, and different ethical frameworks offer conflicting guidance. Some might argue for prioritizing patient A based on utility, maximizing the total years of life saved. A successful transplant for a 16-year-old could potentially save decades more life than for a 55-year-old. However, others might emphasize medical urgency, arguing that patient B, who will die within days without the heart, has a more immediate and pressing need. While patient A is declining, they are currently stable enough to remain on the wait list, potentially for another organ. Another perspective might incorporate the principle of justice or broader societal impact. Does the fact that patient B is a single parent of young children ethically matter? Does the patient's dependency on others factor into a decision about allocating a scarce resource that affects a family unit, not just an individual? Furthermore, one might argue for a simple first-come, first-served approach to ensure fairness and avoid subjective judgments about the value of a patient's life or circumstances. But is this truly fair if the most urgent patient isn't listed first? These conflicting viewpoints illustrate the complex ethical terrain. Prioritizing total years of life might seem logical from a purely utilitarian standpoint, but it can feel cold when faced with a patient who will die immediately without intervention. Prioritizing urgency seems compassionate, but what if that patient has comorbidities that significantly reduce the likelihood of long-term success compared to a younger, more stable candidate? Considering social factors like dependence might feel right, but opens the door for potentially discriminatory criteria based on family structure or perceived societal contribution. There is no easy answer. The decision forces us to weigh competing values: longevity versus immediate need, immediate benefit versus societal impact, strict rules versus compassionate judgment. We've journeyed from understanding the miraculous anatomy of the heart and its vital function through the devastating impact of heart disease and the evolution of treatments culminating in the complex life-saving intervention of transplantation. As our ability to treat heart disease advances, from basic medications to incredibly complex surgeries and even xenotransplantation, our ethical frameworks must evolve alongside. The challenges of donor shortage and equitable access are not just medical problems, they are profound ethical and societal ones. The decisions we make about allocating scarce resources like donor hearts will reflect our deepest values as a society. Looking ahead, research into artificial hearts, regenerative medicine, and further developments in xenotransplantation hold immense promise. But these advancements bring their own ethical questions. Will these new techniques be accessible for everyone, or will they widen existing healthcare disparities based on socioeconomic status or geography? We'd love to hear your thoughts on the ethical dilemma presented. How would you decide between patient A and patient B, and why? Use this video to stimulate discussion about the scientific advancement continuously creating new ethical terrain. Share your perspectives in the comments below. If you found this discussion insightful, please like this video and share it with others who might be interested. Subscribe to our channel for more explorations at the intersection of science, technology, and ethics. And let us know in the comments below what are other ethical challenges in science you'd like us to explore. Your engagement helps us build a community grappling these vital questions.